what he was having me do was to try and work that disc bulge back into the more vertical alignment of the spinal column. Physios are probably cringing at this point.
One, yes, we are cringing because you're talking about stuff that you're not an expert in, and you're pretending you're an expert, and you're not even citing peer-reviewed sources. That's why I'm cringing. Welcome back for part 2 of debunking Andrew Huberman's terrible protocols on low back pain. There are some good gold nuggets, and we are going to try really hard to find those. Some of these things are going to help you. Some of these things are going to waste your time, and you need to know the difference. So I'm going to watch this so you don't have to. And real quick, if you're new here, my name is Dr. Anthony Davis. I specialize in working with people with chronic low back pain and sciatica. But beyond credentials, I'm going to cite the research. So far, my main frustration with what Dr. Huberman has been talking about is that he has not cited a single research paper yet. I hope to God that that is going to change. Let's find out. In this video, he's going to be talking about exercise, quote unquote, protocols, telling you which exercises to do and which ones to avoid. So let's dig in.
First of all, if you have back pain, you need a proper assessment and diagnosis.
Just a quick reminder that having a proper diagnosis actually makes your outcomes worse in most cases. If you have serious red flags, of course you need a proper diagnosis, but most people with back pain and sciatica find that if you get an early and unnecessary MRI, which will give you a proper diagnosis, tell you exactly what's happening in your spine, you're actually 12 times more likely to be pushed into a surgery that you do not need. So actually getting a good diagnosis makes your outcomes worse for most people. And part of that is being pushed into surgery, but even if you're not pushed into surgery, the reason might just be that you get obsessed with the image in your head. You get too focused on the anatomy, and frankly, the anatomy does not matter nearly as much as you think it does, and the more that you stress about it, we find that fear of pain leads to worse disability than pain itself.
I don't want to give the impression that all back pain can be resolved without surgery. There are cases where surgery is necessary.
He's right. Sometimes, unfortunately, people do need surgery. Basically, it comes down to this. This paper was talking about cauda equina syndrome, and essentially we want to watch out for foot weakness, numbness and tingling in the groin, that's saddle anesthesia, like you can't feel it when you wipe, or incontinence, loss of control of your bowel or bladder.
But they're going to have more ability to twist themselves. The spine is going to do that very easily as compared to the person with a thicker torso and spine. And indeed, one of the things that somebody with a thin spine should do, they don't go reaching for a glass up in the cupboard and all of a sudden they have compression of a nerve root coming out the spine because they just twisted it to the side by about 5 to 7 degrees.
First of all, I totally agree with him that getting strong is really important for people who are very hypermobile. I'm hypermobile, and I was able to resolve my own chronic pain when I started to weightlift. So I totally agree with that. I don't like his phrasing that somebody with a thick spine is going to go to reach up in the cabinets and try to grab something and twist, but in his words, by about 5 to 7 degrees and bad sound effect, pinch a nerve. That is absurd. If somebody with a thick spine went to grab something and their back and they had an injury or a spike of pain or a flare-up of pain or something like that, that particular activity was not the thing that caused it. They were probably already overtraining and under-recovered, and their body was already under too much stress. And then that was just the final weird thing that set it off. Also, as far as research is concerned, these are clinical practice guidelines. They don't mention anything about a thick or a thin spine having anything to do with back pain or sciatica. And then here's a little bit more research on why I'm making a big deal out of this. That is, if you are obsessed with the idea that, oh, I have a thin spine and therefore I should avoid these things, or no, I have a thick spine and therefore I should avoid these other things, then you're going to be afraid of movement. You're going to have what we call kinesiophobia. And we clearly see, here's a systematic review that was looking at fear avoidance beliefs and how they are actually a prognostic factor for the outcomes of low back pain. So essentially, if you are more afraid of movement, afraid of the pain, you are more likely to develop chronic, long-lasting back pain. So we need to stop the fearful narratives. And again, it's not just about fear. It's about the fact that the fear that he's promoting is not even evidence-based.
Are the so-called McGill's Big Three. named after Dr. Stuart McGill.
Real quick, Stu McGill is one of the leading spinal biomechanics researchers in the world, and I even had the opportunity in school to interview Dr. McGill for an evidence-based student club that I ran. I have a feeling he's about to say some things that are very not evidence-based, and I'm definitely going to debunk some things about the McGill protocols. But I'm saying it with respect, but it gets taken out of context a lot and leads to bad places and a lot of places of fear, a lot of places of people feeling the need to brace and protect their spine all the time. Some of his research does not apply clinically to real human beings.
Everyone I spoke to all agree are extremely useful for everybody to carry out.
All the people you talked to? How many people did you talk to, man? I have a feeling that Huberman doesn't actually know much about the subject of back pain and sciatica, because if he did and he knew which people were the most prominent figures in the research space, he would have talked to Peter O'Sullivan, who has written tons and tons of research on the biopsychosocial model of healthcare and really thoroughly debunking a lot of the outdated myths that we're talking about here with McGill's stuff and these biomechanical boogeyman. And Peter literally tweeted basically that he doesn't agree. Fortunately, Huberman might take him up on an episode. That would be an episode worth watching because O'Sullivan actually knows his stuff on back pain and sciatica.
If you are crunching, you can imagine that's essentially bringing the vertebrae together in the front of that sandwich that is vertebrae, disc, vertebrae. And what it's going to do is it's going to have that disc bulge out even further. It's going to herniate even further and impinge on those nerves even further.
Okay, what he's talking about is called the dynamic disc model, and it's these stupid models where if I press on the front of the disc, you can see this disc herniation comes out the back because I'm pressing on the front and it pushes the fluids basically out to the back. The problem with this model is that this is total bullshit. This is not how the discs actually work, okay? First of all, the discs are not fluid. They're f***ing cartilage. And second of all, we have research like this amazing MRI image right here, where we actually have somebody going into flexion, bending forward, and we look at the disc bulge or disc herniation in this case, and then we look at it during extension. And in this case, we see that for this person, flexion actually resorbs the disc. So unlike this stupid, inaccurate model where you bend forward and the disc herniation goes out the back, for this person, bending forward actually sucks the herniation back into the disc. And then when they go into extension, it actually herniates and bulges or swells up worse. But even then, it's really not the end of the world. But the point is, this research, again, he's saying these things without citing any research. What he's doing is what we call an appeal to authority, and it's a logical fallacy. He's basically saying, well, Stu McGill says this, and therefore I'm just going to repeat what Stu McGill said. And in this case, for this person at least, it's definitely not true. In fact, it's the exact opposite.
And this is important. Your tongue is on the roof of your mouth.
He's making things way too complicated. You don't have to put your tongue on the roof of your mouth to do a McGill curl up for low back pain and sciatica. Okay, he literally describes how to do a crunch for 10 minutes. I'm going to do it in 10 seconds. You lay on your back, your hand is under your low back, and you only crunch the upper body. So you're basically doing a crunch without moving your low back. Okay, simple. And there's a picture. Okay, so the whole point of the McGill curl up is basically to be able to activate your abdominal muscles without bending the spine. But this operates from the assumption that bending your spine is somehow a bad thing. But we need to go back to the bigger picture question, which is it actually a bad thing to flex your spine when you have a disc herniation? And I've already showed research that shows that for some people, flexion actually resorbs the disc. So it's definitely not true for everybody. But here's a bit of research looking at, should you flex, should you not flex? Basically just trying to see if flexion of the spine is a prognostic risk factor for low back pain, meaning is flexing your spine bad for your back and is it going to cause back pain? And no, the answer is no. And I could easily cite more studies on this, but this is a good systematic review with a meta-analysis, which is kind of the gold standard again for research. We want to look at lots and lots of research. So these review papers are typically the best evidence. And again, I want to highlight the role of fear in actually making pain worse. And in part 1 of this critical review series on Huberman, I cited a paper that suggested that pain makes you actually more tense. So people with back pain have a more tense core. So we want to actually relax your core and allow for bending of the spine, because if you're just tense and tight and braced all the time, your muscles are fatigued, they're irritated, they're not recovering. And again, I want to go back to the thing where he said to push your tongue on the roof of your mouth in order to do a curl up, which is absurd, because we know from research like this paper here that perfectionism, it makes performance and rehab worse. The more that you hyper-focus on how to accomplish the task, the worse you are at actually accomplishing the task. We want things to be natural. We have a paper here showing that perfectionism leads to burnout more often in athletes. So once you're out of the woods with pain and rehabilitation, and you start to look at athletic performance, and I believe this would still apply to rehab context as well, the more you hyper-focus, the more you're going to get burnt out and the less success you're going to have long-term.
The second exercise in the McGill Big Three is the side plank. If they build up through a set of incremental steps, making sure that the form on each of the steps is absolutely perfect. So
again, let's just go back to this paper. Perfectionism really doesn't matter, so you don't need to get the exercise perfect. More importantly, here's a systematic review and meta-analysis looking at graded activity and graded exposure. This is the most important thing, okay? And he's right about this, that if you want to get into a side plank, you don't just start by doing a side plank, you start by doing easier variations. And he goes on to break those down. But the short story is, I totally agree that starting with easy things and then gradually working your way to harder and harder things over time is, in my opinion, the single most important aspect of any rehab program. And I would argue that it does not matter what exercises you're doing specifically, and that it doesn't matter very much the technique in which you're doing it, because you can get away with pretty sloppy techniques as long as you're doing an exercise that is easy enough to not irritate your body. So he's saying, oh, do the McGill Big Three, avoid bending your spine. But graded exposure means deliberately bending your spine. If that's the thing that is the most sensitive, that's the thing that's the most fear-provoking for you. We want to kind of poke the bear a little bit, because not only does it improve pain and function, but it also reduces kinesiophobia and therefore disability. So again, the most important thing about any rehab program is not picking some magic collection of exercise. We need movement.
Stu kind of cringes every time people say, okay, it's just McGill's Big Three. He knows, and it's true, that there's a lot more involved in strengthening and pain-proofing the back.
And this is why I'm throwing no shade at Dr. McGill, because he knows. If you actually talk to the guy, then he is well aware that his Big Three are not magic and that people need to actually strengthen. But the problem is, even when people read his book, like The Back Mechanic, people come away from it thinking all they need to do is the Big Three and hip hinge and brace their core all the time and never bend it, and basically be afraid of bending and be terrified that you're going to make some terrible thing happen to your disc. Look, at the end of the day, that's the impression that it gives off.
Absolutely stop doing any abdominal crunching. Just stop. You're making it much, much worse.
And this is exactly the kind of fear that we're talking about. This was an interesting research paper that looked at, well, should you crunch or should you not crunch? And does it matter for injury risk and back pain? And essentially, no. The answer is no. Meaning, as long as symptoms allow, as long as there's a tolerable level of mild to moderate pain, but it doesn't get worse after doing crunches, there's nothing wrong with crunches. Now, in fairness, like this paper compared doing flexion-based exercises to extension-based exercises, and in general, for many people, extension-based exercises do tend to feel better. But that is not an argument that you need to avoid flexion. In fact, it's kind of the opposite in my opinion. It's saying, oh, we can't do that thing. That is not normal. Normally, you should be able to do flexion. You should be able to bend your spine, crunch, round your spine, pick things up off the ground, all that kind of stuff. So the answer should not be to avoid the things that hurt. The answer should be to gradually expose you to be able to eventually do those things that previously hurt you, like flexion bending. Huberman was just telling a story about how he had back pain, and when he went to a physical therapist, they told him, well, stop crunching because crunching is terrible for your discs. You need to stop that immediately. Well, it sounds like his therapist is what we would call kinesiophobic, fearful of movement. And this was an interesting paper where we looked at physical therapists who had kinesiophobic beliefs. They had fear of movement. And then they looked at what is the lifting capacity of their patients. And no surprise, they found that when therapists are afraid of lifting, they pass those fearful beliefs on to their patients, and their patients are also less strong and less functional. Here's another study showing that physical therapists who have fearful beliefs transfer those fearful beliefs onto their patients, and they make bad clinical decisions, so they're worse clinicians. And as far as their patients' outcomes, well, their patients get worse outcomes compared to physical therapists who do not have these outdated kinesiophobic beliefs. And the more fearful a physical therapist is, the less likely they are to follow current evidence-based practice.
The curl up, the side plank, which we've covered, and now the third, which is the bird dog.
Okay, so he goes on for like 10 minutes just describing how to do this really simple cookie cutter exercise that all of us, if you've done rehab for back pain and sciatica, everybody's already gotten a bird dog. This is not magic. You've already seen this a million times. It's really straightforward. The whole point of the bird dog is to try to move your leg and your arm without bending the spine. Okay, so this is just another way from McGill to exercise basically without moving the spine. So these are spine-sparing exercises. There's nothing wrong with spine-sparing exercises. If things are absolutely too painful to do any other type of movement or exercise, then spine-sparing exercises are fine. It's a fine place to start. But it comes from a place of fear, a fearful place of saying it's bad to bend your spine. And it's not bad to bend the spine. I've already shown you an abundance of literature showing that flexion is safe, that crunching does not cause low back pain. Flexion does not necessarily cause low back pain, but it's actually beneficial to push through a little bit of pain. Not too much, but a little bit of it is actually a good thing.
Have the extended hand in a fist.
He claims that you must squeeze a fist as you're doing these exercises, specifically the bird dog. I don't necessarily have a problem with that. That's actually not incorrect. So there's something called Sherrington's law of irradiation, and we find that creating tension in one area of the body does indeed allow us to create more tension and more muscle engagement through the rest of the entire system. So irradiation is fine. Again, here's a paper kind of talking about Sherrington and his ideas. Is it necessary to do the exercise quote unquote correct? No, I would view this as a progression. So when you start off with the exercise and you're first doing this for the first time and you're in a severe amount of pain, just doing it nice and gentle is probably more beneficial, but then eventually being able to irradiate tension and pressure and creating a full body muscle contraction would be helpful.
Imagine an Oreo cookie. So it's a good analogy here where you've got the two cookies and the cream center. So the two cookies are now...
No, it's not a good analogy. It's a terrible analogy, and it's one that paints the spine as being fragile. It's almost as bad as the jelly donut idea. That idea makes you think that your spine is fragile. These models make you think that your spine is fragile, but in fact your spine is resilient and the discs are made of tough, rubbery stuff. And that if you go with the jelly donut or Oreo analogy that he's using, you think that the jelly just goes in a particular direction, but I've already shown you research that that's not necessarily true. And I've shown you research already that shows that these fearful beliefs actually worsen your disability and pain and prolong your rehab.
Pain is always the consequence of a pathway being irritated or a pathway being activated.
Not necessarily. Pain does not necessarily have to involve what we would call a nociceptive pathway, meaning sensations that are traveling from an area of the body up to the brain to inform you of some kind of danger or damage. This paper, of course, looks at the various types of nociceptive and behavioral pathways, and ultimately what we find is that pain is in the brain. Pain ultimately does not happen until it becomes a conscious experience, and that experience could indeed be from nociceptive signaling, in other words, sensation from the body, but it could just as easily be from a reactive state where the body is anticipating damage or danger, and therefore it preemptively activates the pain alarm system. So technically all pain happens in the brain. And then in this paper, we see that sensitization can happen without pain or without damage. So an area can be hypersensitive chemically, hypersensitive, but it can do that without being damaged. He should have been talking about the neuroscience of pain, the real neuroscience of pain, which is not nerve compression, it's nerve hypersensitivity, it's chemical sensitization, it's literal opiates in your spine that are painkillers versus inflammatory chemicals that make nerves more sensitive, like CGRP and substance P. Or if I wanted to talk like Huberman, I'd just say the neuroexcitatory pain modulating chemical mediators, like, why do you make things so needlessly verbose? It's just inflammation. It makes your nerves sensitive. It's easy. And besides, we have many different types of pain. We have nociceptive pain, which is pain that is what most people think of, which is where a sensation comes from the body and tells your brain, hey, there's something that's damaging us, and therefore we have pain. Then we have neuropathic plastic pain, which is pain that's caused by a lesion or disease of the somatosensory nervous system. And then we have nociplastic pain, the third type of pain here in this paper. And they're just describing pain that is happening from basically a faulty pain alarm system or hypersensitivity. In other words, there's no damage and yet you still have pain.
Now, what about reversing herniation of the discs?
What about it? Well, it turns out that 2/3 of disc herniations spontaneously heal on their own. And whatever he's about to tell you is not something that's going to magically heal your disc faster or increase your chances. The reality is that discs do heal, just like getting a cut or a bruise heals. Most of the time, things heal. Sometimes they don't, but most of the time, 66% of the time, they do.
Push things back by doing a spinal extension, by creating an arch in the lower back.
Okay, so he talks about cobra press-ups, which are, again, a total cookie cutter, starter package for back pain and sciatica. They do tend to help a lot of people, but that exercise alone is not a rehab plan. It's one exercise. So if it feels good, that's fantastic, but it does not replace a full body general strength and conditioning program to ease you into full body exercise, okay? Slowly, but using your full body. And again, when we look at a systematic review of the literature on McKenzie back extension or McKenzie-based exercises, we see that they don't seem to have any unique benefit.
Essentially, what he was having me do was to try and work that disc bulge back into the more vertical alignment of the spinal column. Those in physios are probably cringing at this point.
All right, I'm going to stop you right there. One, yes, we are cringing because you're talking about stuff that you're not an expert in and you're pretending you're an expert and you're not even citing peer-reviewed sources. That's why I'm cringing. So let's cite peer-reviewed studies. Here's a systematic review of the dynamic disc model that he keeps talking about as an Oreo donut. The idea that if you press on the front, it squirts out the back. Well, guess what? That's been widely debunked. Sometimes, yes, it does follow those fluid dynamic properties, but sometimes it doesn't. And it really, really depends. So the idea that the disc is just this like bag of jelly or the cream on the inside of an Oreo is ridiculous. It leads to fear and it is inaccurate. Also, the way that discs heal is not necessarily that you put the cream back in the Oreo. A lot of it is actually an immune reaction. Your immune system has never seen the material of the nucleus pulposus, the disc material. So as soon as you have a disc herniation, your immune system says, whoa, what the hell is all this stuff? And so a lot of the pain and inflammation is not due to nerve compression, but due to your immune system trying to recognize it because it thinks it's a foreign invader and gobble it up. So part of the way that discs heal, at least part of it, is that your immune system literally eats away at the disc. It's like your body performs its own microdiscectomy naturally, which is really cool. Your body almost performs surgery on itself. It's very, very cool. So a lot of the pain is not damage, it's just inflammation from a natural immune reaction. All right, let's cut to the chase. Basically, this entire 2-hour-long podcast is talking about very specific exercises that are the most generic cookie cutter exercises you could possibly get. You go to any physical therapist ever on the planet, and they're going to give you bird dogs and side planks and cobra press-ups. That's just your starter package. Okay, so it's not bad advice. It's just really cookie cutter stuff that doesn't teach you real principles about how to determine which exercises are appropriate for you. How intense should your exercises be? How much pain should you push through, and what type of pain should you avoid during exercise? His podcast goes on and on and on about anatomy and these specific exercises, but actually teaches you nothing to self-manage. So let's look at the big picture. All the exercises that he named are fine for somebody, right? But they're just a starting place. Or for somebody, it might be too hard. The point is, exercise does work. So you should exercise. I 100% agree with that. Here are clinical practice guidelines that show, as usual, in every clinical practice guideline published, we're going to find that exercise is the number one most important therapy for back pain. And then here's a Cochrane review that shows the same thing. Exercise therapy is effective for back pain, but it doesn't matter which type of exercise you're doing. And then here's an interesting meta-analysis which is just a giant review of all the papers that are available to date on core stability exercise versus general exercise. Now, most of the exercises he's suggesting are core stability exercises, which are fine, but they're not better than normal exercise. This paper found that core stability exercises can be beneficial for people in the short term when they're in severe pain and they can't do anything else. Then a focus on core and bracing and stability and trying to avoid bending your spine a little bit because it's irritating Yes, of course that can have a unique benefit when people are in severe pain and they are unable to do any form of exercise other than that. However, when we check in with people later down the road and compare the core exercise group versus the general exercise group, we found that they both get the same result long term. So core stability or specific exercises can help you while you're in a severe flare-up, but long term, to get out of the weeds of chronic pain, if you've been dealing with pain for months and months and months, then you need to stop it with the core exercises and move on. And then once again, he goes on and on about anatomy. He puts this really excessive focus on anatomy, but here we have a paper that's showing that the psychosocial factors of a person's life actually have a huge impact on the progression or predicting whether or not they're going to have future pain. I would argue that psychosocial variables are more important than the findings on the MRI or the disc herniation. On top of that, other factors like smoking seriously increase your risk of developing chronic back pain. And then beyond that, they've even done things where they inject the disc itself to intentionally just piss it off. And even though it did cause pain in the short term, it had no long-term consequences. So we can actually intentionally damage the disc more while you're in severe pain. And even pissing off the disc intentionally doesn't seem to predict whether or not you're going to recover long-term. So let's give you an overview. Big picture, I agree with the general sentiment here. He's promoting self-management. He wants you to be able to do things at home to take care of yourself. And a lot of those things are natural exercise-based techniques. So big picture, I am very much in alignment with him, and it doesn't matter what my opinion is. The research is very much in agreement with him. Exercise is fantastic. It is the number one, it's first line treatment for back pain. He's trying to solve the problem by giving you exercises, but in the process, he creates new problems by giving you fearful, outdated, inaccurate anatomical explanations about how the back actually functions. He gets basic anatomy wrong. He doesn't understand that the dynamic disc model has been thoroughly debunked and is no longer applicable. He emphasizes the idea that all of these exercises have to be very, very specific. Otherwise, you're not going to get the benefit out of them, or you're going to do it wrong and make yourself worse, which is not true. And in 2 hours of a podcast, he failed to cite a single piece of research. He should hold himself to a higher standard. If a student wrote a paper for him and didn't cite their sources, he'd give them an F, right? So I guess I'm going to have to give Huberman a big fat F on this podcast. You failed, dude. You didn't cite any sources. Overall, this podcast comes across as exactly what it is. It's a person who is speaking outside of their field of expertise about a subject that they are just not very familiar with. This podcast went the same way that if I tried to make a podcast about dermatology and skin health, it would probably go about the same. I would get the surface level stuff. I'd probably catch all the cookie cutter stuff that is generally recommended from most popular figures within the dermatology space, but I would probably miss the fundamental understanding of pathology. I would not have a familiarity with the literature, how research is conducted in that particular field, what are the gold standards to watch out for, and what are all the counter arguments against the status quo. He does not have a familiarity with that research. He didn't quote any research, and the ideas that he's promoting are cookie cutter, outdated, or dead wrong. So although I agree with the general sentiment that exercise is the way to go, that movement is medicine, and that you should be able to take care of yourself at home naturally in most cases, and I agree with that self-efficacy message, he totally misses the mark on all of the specifics. Hey, let me know in the comments right now, what did you learn today in this episode? Through this series, was this helpful? And specifically, what did you learn that has debunked some old, outdated, or possibly fearful beliefs? And if you know somebody who's dealing with back pain or sciatica, be sure to share this episode with them so that they get the facts straight. And lastly, if you'd like an evidence-based approach to understand what really causes back pain and sciatica and what to do about it, I have a masterclass to teach you about how to conquer chronic back pain and sciatica without drugs, medications, surgery, or complicated exercises. The link is always in the description of my videos, so check that out, and I will see you in the next episode.